Hello, everyone. Hello, I'm Sue Cole,
And I'm Matthew Hodson.
and welcome to aidsmapCHAT, the last of this series.
Yes, it is. Well, let's not get upset about that. We've got a fantastic lot of guests coming on. You just moved. I don't know what that's about.
Having all manner of technical, interesting things happening in this show. So
well,
far, it's going to be really exciting.
whilst you sort out your Dalek voice, I'll just introduce who our guests are going to be. Or I can hear you as Dalek voice. Are you hearing me as Dalek voice?
I'm hearing you as a Dalek voice.
Oh gosh. Okay. Right.
So, yeah.
Oh, in which case it may be my headset. Honestly, to the people who are watching live right now, we did a sound check and everything was fine. Oh, looks like it's just me. So I'm going to tell you who we've got on the guest as guest this week. We have an epidemiologist and an assistant professor at Harvard Medical School, who is Julia Marcus. She has recently written a wonderful article which is talking about how we prepare to deal with COVID on a long-term basis, recognizing that our lives may be different and that maybe some of the restrictions which we're currently just about able to manage, we're not going to be able to manage if we have to carry on doing it for months and months. So that's going to be a really interesting conversation. We've also got Winifred lkilai from Uganda. She works with the AIDS Vaccine Advocacy Coalition. And you may be aware that on Monday, it was the International HIV Vaccine Awareness Day. I think I've got that right. So it'll be really interesting to talk to her about all of that. And we also have the amazing Shannon, who is the Deputy Executive Director of UNAIDS. So she is obviously incredibly busy right now because we're seeing with stories from around the world how COVID is affecting people living with HIV and the additional pressures that it's putting on health systems. And unfortunately, the additional, hello, the additional mortality we're seeing as a result. So, Susan, talk to me and tell me something. Let me hear how you sound.
Well, I just wonder what you were saying. Bet you thought you had your moment and you would be able to do all of the show without me.
You know what? I never thought I'd miss you until just then. And then I was just like, it's just not the same without her. Bring her back. I don't care what anyone else says. I want her back in the show.
Excellent. So, Matthew, I don't know what you've been talking about because I have disappeared.
I was talking about your protein bar incident, actually. Because every week Susan comes on the show and she tells us something about, some fast food that she has eaten or aspires to eat. And I know that just before this show started, she accidentally ate a protein bar, which was intended for bodybuilders. Is that right?
That is indeed, yes, it is my rugby playing son's protein bar. And yeah, I'm getting quite a rush. I thought it was just the menopause in terms of like how hot and sweaty I am. But I'll be fine. I'll just get like a nice KFC delivery at the end of the show and I'll be okay. So, Matthew, has there been anything in the news this week that struck you?
Well, I think a big story which we featured on AIDSmap this week has been about a new trial of injectable PrEP. Now, this has been in the pipeline for a while. In fact, we ran a story just last year about injectable treatment and acknowledging that it could also act as PrEP. And there's a study, HPTN 083, there you go, which they actually closed the study early because they had two wings in the study. One wing was people who were receiving the injection and a placebo pill, and the other people were receiving a placebo injection and the actual pill. And the people who received the injection had much lower or considerably lower rates of HIV acquisition. So it's really exciting news. Now, some people are saying, well, what's the point? Because we know that PrEP as a pill works really well, and that is true. But we still have challenges with adherence, and we also reported on AIDSmap this week excellent site, by the way. We also reported it on aidsmap this week about people who, there was a study of people in the US who were on PrEP, stopped PrEP for a variety of reasons, and then went on to acquire HIV. And some of those reasons may be about adherence or maybe about ability to continue to access PrEP. So if you have an injection which lasts for 2 months, it's going to be much simpler for some people. I mean, it is an injection in the butt, and there may be some soreness involved. So, I'm not saying this is like it's going to be the solution which everyone chooses, but I'm always good for options, good options. And it's a big study as well. It's 4,600 people, gay men, bisexual men, and transgender women.
Absolutely, and it's a really exciting study. Obviously, I'm really keen to hear about injectable PrEP for women, but I know that there's a study, HPTN 084.
Oh, you said that so smoothly. It's just like rolled off your tongue. So what does HPTN stand for, Susan?
Well, let's just move on from there. But I know that study has 3,000 women in Africa, and they're looking to see if that's going to work. So fingers crossed, we should get the data within the next few months for that.
Yeah, so it's going to be really interesting, and I think often for, perhaps particularly for women, that sometimes there's real concern around taking pill form of PrEP because it can be not very discreet. And if you're in a relationship where it may be difficult to disclose to your partner that you're taking PrEP, because it may suggest, for example, that you don't trust your partner to be monogamous with you, that's maybe something that's going to really help a lot of women. So I'm really excited about that.
Absolutely. So talking about a lot of women, I think that we have got a lot of amazing women coming on the show this week.
Such a great segue. I mean, that's incredible. So good. So good. No one noticed. Seamless. So who's our first guest then?
Well, so I mean, looking at the background, your background is looking okay. I mean, obviously mine, I usually have the NAM stand in the middle of my house.
You mean always. That's not it's your actual wallpaper?
It's I'm even wearing like NAM magenta. You just really need to get with the program, Matthew. We're just not sufficiently committed.
I've got my fish. I've got a NAM magenta fish tank.
But I think we have a guest who has received accolades for how brilliant her background is. So shall we bring on the incredible Julia Marcus from Harvard Medical School?
Look at that background. I mean, I'd give that, I don't know, apparently you only got 8 out of 10 for that. On the Rate My Skype room.
I know, and they didn't tell me how to make it better. So I don't know, do I need like a plant or some books? I'm going to work on it.
I don't know. It looks perfect to me. So great to have you on the show, Julia.
Thanks for having me.
So I mean, I wanted to invite you on because I read this article, which was it in the Atlantic? Was it published? And I thought this is so important right now. And I guess I felt that because as a gay man, and I remember when HIV kind of first hit us and the kind of discussions that people were having. And initially, the advice was, well, if you're a gay man, stop having sex, which was never an option I considered very seriously, to be honest. And I think it was that kind of partly as a thing of, well, this is only a temporary measure. And at the time, when certainly in the UK, the government was much less sympathetic towards LGBTQ people, the idea that gay men wouldn't have sex, I don't think they were particularly concerned about that. It's becoming increasingly apparent that we're going to see restrictions on the way that we're able to interact with each other as a result of COVID for quite some time yet. So how do you think we should be building our resilience now?
Yeah, I mean, I think what we've been doing made a lot of sense for the last couple months. And early March, there was this message kind of globally to stay home. And we all thought, okay, it'll be a few weeks and we can do this. And now it's becoming clear that this is something we're going to have to sustain for many more months, if not years, until we have a vaccine or a preventive medication. So I think now we need to be thinking about sustainability. And I think we can all agree, just like you're talking about with the early days of AIDS, we can't stay in our houses until there's a vaccine. So we have to find ways to engage in our lives, not the way we did before, but a new normal that allows us to have some semblance of joy and pleasure without vastly increased risk of coronavirus transmission. So we really need to be looking for those low risk activities that allow us to live our lives in a sustainable way.
Brilliant. I saw your absolutely brilliant infographic about the spectrum of risk. Can you share some of the tips?
Yeah, I mean, the idea is, instead of an approach where we think about staying home versus going back to life the way it was, we think about a whole spectrum of risk. What's the gray area? What's the middle ground? And if we think about it from, if we go back to that analogy of the early days of HIV, it's like shifting from abstinence-only messaging to safer sex education. So what are the ways that we actually can engage in this activity but keep our risk low? And if we think about a spectrum of risk from what we know about COVID-19, obviously staying at home is going to be our safest option, but that's not something we can all do forever. We may be doing much more of it than we normally would, but we need to think about ways that we can be outdoors. We know that being outdoors is lower risk than being in a crowded indoor setting with people outside of our household. So, and also thinking about harm reduction strategies for every scenario, like keeping 6 feet of distance wherever you can, and wearing a mask and keeping hands clean, kind of all those same messages that we've been getting, but with a bit more nuance that gives us a sense of, not just staying home, but other things we can do that are relatively low risk.
Yeah, I guess one of the things that I've really noticed is, you see kind of real invective against people who are like breaking the rules, and I think that's I understand that and I get that, because I think everyone is going through a bit of stress, and for some people actually kind of shaking their fist at people who don't seem to be following the rules which they might want to follow is actually also a way of releasing their tension.
Mm-hmm.
But at the same time, we also know how abstinence programs worked in a variety of different settings. And when I kind of paused before I said worked, it's because we know that ultimately they didn't work well. And in fact, what happened when the abstinent message was preached, often it led to people not really having any understanding of how to reduce harm or risk if they then did engage in an activity. And that's what we saw.
Exactly. And the shaming that you bring up is also not an effective strategy. And if we think about what still goes on today with shaming of, let's say, condomless sex, the result is that people won't disclose to their provider that that's something that they're doing. And then their healthcare provider doesn't know what kind of care that person needs. And it ends up actually backfiring, and we end up with worse health outcomes. And if we kind of think about how that would work today, you could imagine if people who are getting together in a park having a picnic are shamed, they may take that indoors, and it may become a crowded indoor dinner party where it's actually higher risk than if they'd stayed outdoors. Or, if there is an outbreak and contact tracers are looking for people who may have been exposed, people may be afraid to say, I was at that event, because they're afraid of being stigmatized for doing that. And so I think even though shaming is a natural instinct for some, and it's understandable right now with high levels of anxiety and anger, which is all justifiable, I think we need to remember that it doesn't usually have the effect that we want it to have.
Thank you.
Brilliant.
So great to have you on the show. And I look forward to meeting you at some point when we are able to move around a bit more.
Thank you so much, Julia.
Thank you for having me. Bye.
Can you believe it is the last show? And I don't know. It's weird because this has been such a trip for me, to be honest, and it's become something which is kind of quite different from what I first expected it to be. And I think for me, it has really felt like it's been about communities, and what I've felt doing this show, and with all the people I've spoken to, is I felt a really strong sense of being part of an international community of people living with HIV, and I've also felt really just blown away and incredibly moved by some of the examples we've heard about community responses, how people are literally getting on their bicycles to make sure that people have access to treatment, around the world. And that has been, just, well, it's been a really moving part of the process of me. Oh, stop it. Don't look at me like that.
It's been absolutely incredible. And I think in relation to the community response, I believe this is a perfect segue to bring in an extraordinary representative from the community who is...
Hi, it's Winifred.
Hi, Matthew. Hi, Susan. How are you?
Oh, we're really
great.
good.
Thank you. A little stressed by the technology, but hanging on in there. Winifred, thank you so much for coming on. What's been the community response in Uganda?
Thank you so much. So we first registered a COVID case on 31st March. And from then, we had a lot of challenges as people living with HIV because, one, the lockdown measures which were imposed by His Excellency affected the quality and access to treatment. So people found it quite challenging to walk to the health facilities to access treatment because of the long distance. And also we've had so many challenges around sexual and gender-based violence due to the lockdown. So communities have really played a great role in ensuring that people living with HIV access treatment. We've had networks of people living with HIV. We've had expert clients being able to deliver drugs to people out there in the community. But also we've been able to advocate and engage the Ministry of Health through the PLHIV COVID response team to ensure uninterrupted access to treatment. I think you saw so many photos of young men riding bicycles to deliver drugs to people in the community. Yes.
Fantastic.
It has been fantastic. Now, I do want to talk with you, Winifred, about vaccines because, as I mentioned at the beginning of the show, Monday was International HIV Vaccine Awareness Day. And, because of what I do, I hear a lot of stories. I hear a lot of frustration about how long it's taken to get. Well, we haven't got an HIV vaccine. We're still exploring avenues, and of course, we're 40 years into the epidemic now, and I guess this also makes me concerned about when a vaccine does, we hope, materialize for COVID. How will we roll it out? I mean, do you think that the challenge we've had in getting a vaccine for HIV, is it because not enough resources has been put into it, or is it because it's really difficult?
Or both?
Yes. First of all, we must understand that HIV mutates. It keeps changing shape. I usually call it a moving target. So because it keeps changing shape, it becomes difficult for the antibodies to infuse and neutralize the virus, unlike other diseases. So we find it quite challenging because HIV has different subtypes and has taken quite long to deliver a vaccine trial because of such challenges. And also maybe to add on that, it is quite challenging to also find an effective way of delivering HIV proteins into the body in a way that the immune system will respond without necessarily causing HIV. So that is the biggest challenge with getting an HIV vaccine. The HIV mutates, and a lot of trials are happening. Right now we have the AMP study that is happening, that is trying to test whether neutralizing antibodies can mitigate HIV infection. But we cannot lose hope because of that. We shall keep trying to see to it that so many trials are supported. Yes.
Okay, thank you. Obviously, in relation to a COVID vaccine, if and when we do actually get one, I think it's hugely important that it's made available to everyone in the world, regardless of where they live. What do we do right now to make that a reality, do you think?
Right now, you also must appreciate that with COVID-19 vaccine development, the process is really moving on so fast because we are borrowing from the scientific knowledge that has been generated from HIV vaccine research. So to ensure that people access the vaccine equitably, one, we must ensure that we have enough manufacturing plants in place. Enough vaccine should be manufactured such that all people are able to access it. And we should also be asking ourselves the question of the cold chain, supply management. How are we going to ensure that different countries right now affected by COVID-19 are able to access the much needed vaccine? In addition, we must also ensure that we involve the community. Community engagement is key in planning and delivery of a safe and effective vaccine. One, we must empower people and also ensure this social mobilization, people to demand in the light of resources. I would love to borrow the GPP principle from HIV vaccine trials, where communities have been involved, HIV vaccine platforms, to ensure a safe and inclusive vaccine is delivered, but also the great collaboration and partnerships by the different manufacturers and trial networks. So I think that should really be put into consideration, delivery and the manufacturing process. Yes.
Yeah.
Brilliant.
It's such a concern, isn't it? I mean, you kind of, well, I mean, I guess it's also such a concern that we don't know when or if a vaccine will be available, but we do know that history tells us that it's getting the technology is one thing, getting it implemented, getting it out there is a different thing altogether. And it's really vital that we make sure that everyone benefits. So, Winifred, it's so lovely to see you. Thank you so much for coming on.
Thank you so much, Winifred. Take care.
Thank you, Susan and Matthew. It was awesome connecting with you.
Oh, thank you.
And you. I think it's really funny that Winifred said on Twitter today that we were calm. I think she's actually getting a taste of the reality that really isn't quite the case.
Yeah, I like to think that we glide serenely like swans, but but we all know under the surface there's a hell of a lot of paddling going on. Yeah, so I mean, we started doing this show because we felt that it was really important to provide information about COVID, particularly for people living with HIV. We recognized that there were a lot of questions and that there were new challenges being posed by COVID. We have got a bit more data has come in since last week, looking at COVID amongst people living with HIV, or looking at HIV positive people amongst those who have been hospitalized for COVID. We're still not seeing anything which gives us anything which really says that people with HIV are more likely to acquire COVID or are more likely to have severe impacts. But there was some data around bacterial pneumonia and people with HIV being more likely to die with bacterial pneumonia and COVID than people who weren't HIV positive. And it's still very early days. I guess this does tell us, well, the things it tells us is we recognize that it's an evolving situation. We're not going to see dramatic increase in risk for people with HIV because we've got enough data now that we know that that isn't the case. We may see some slight differences as we get more data in and understand it better. And it does also underline the importance of ensuring that good medical records are kept so that we can see whether there are differences for people living with HIV than there are for other people, because we know as a result of COVID, we're going to see steep increases in excess mortality, in every region that's been affected by it. And it will be deaths from AIDS, it will be deaths from TB, it will be deaths from malaria, often among people who are uninfected with COVID as a result of the strain placed on the healthcare system. So
yeah, that's very sobering. But if only we had someone from UNAIDS who could
queen this week, can't you? I mean, who do we have? Who do we have in the waiting room?
We had
Ah,
The Deputy Executive Director of UNAIDS, as if by magic.
so
Hi,
hi,
Shannon.
Shannon. So
Hey,
thank you very much
everybody.
for joining us. Yeah, I mean,
Thank you.
so we were talking about kind of excess mortality as a result of AIDS and malaria and TB, and because of your role at UNAIDS, you're going to be responsible not for the excess mortality, but for addressing that challenge. So what is UNAIDS doing about this?
Yeah, a few things. I think one of the first things we did was say, well, what would be the cost of inaction? Like, what happens if we just put everything on hold while we're responding to COVID and then pick it up later? And we worked with WHO and the HIV modeling consortium, about 5 big HIV modelers, and looked at, okay, if all HIV treatment services, for example, were put on hold for 6 months, we're just discontinued for 6 months. Now it's our job to make sure that doesn't happen, right? But if that happened, what would be the cost in terms of human lives? And the models showed that in sub-Saharan Africa alone, that could result in an extra 500,000 deaths this year alone. That doubles the number of deaths that we had from last year, and it takes us back to 2008 levels of deaths. So I think, this is just a quantitative reminder of we must have the political will to continue HIV services while we are responding to COVID. These should not be seen in competition, and we've just got to make it happen.
No, absolutely. Yeah, thank
so
you.
Some of the things that we're doing about that is, we reached out as UNAIDS and worked with our networks of people living with HIV and at risk for HIV, and said, what do you need? What do you feel like you need? Whether it is information on COVID, prevention resources for COVID, HIV treatment. And the number one thing from networks around the world that came in consistently as most important is, I'm really afraid I'm going to run out of my ARVs. I'm going to run out of my HIV treatment meds. I am fearful that I will have a treatment interruption. So that's a lot of what we've been working with partners to really focus on making sure it doesn't happen.
Yeah, that's absolutely fantastic. Thank you for all you do. I mean, we've learned some really important lessons in the HIV response. Which of those lessons do you think are relevant to move forward when we tackle the COVID epidemic?
Yeah, so many, and I think you've been touching on some of them throughout today already. So maybe I'll just pick maybe 3. I think 3 things from the HIV response that are absolutely fundamental to a successful COVID response. One is an effective public health response is also a human rights-based public health response. Second is you've got to have communities in the lead, and by communities, we mean nothing about us without us. Communities of affected people for affected people. And third, just like HIV is a virus, but it's a health condition, but it's never been only about health. COVID's a virus, but the response is not going to be just about health. So maybe, starting from the top, we hear a lot under COVID, it's like, oh, there has to be a trade-off between the public health response and the restrictions and human rights, and people just have to expect that. It's like, well, no, you can have restrictions that are still grounded in human rights and gender sensitivity. We know this. And in fact, we know from the HIV response, if you don't, you will never get to the end of your epidemic. Because if your restrictions are draconian, if they're not flexible, if they're not evidence-based, if they're not time-limited, if they're not appropriate, you will push people into hiding and not get the cooperation and collaboration you need. When it comes to community-led organizations and leaders being in the response, we know this is a matter of being at the governance tables and the planning tables. We know it's about helping deliver direct services to people who need them most. And we know it's about community monitoring, being able to hold providers and the government accountable for delivering on their promises to the people. And in COVID, we're starting to see that engagement of community-led organizations in some of the service delivery. We talked about preventing treatment interruption. We are seeing community-led HIV organizations around the world really step up to help make sure that people get their drugs. But what we're not seeing yet in COVID, despite the fact I can tell at UNAIDS we're fighting for this in every country, is the incorporation of community leaders at the governance table, at the decision and planning table, and that's just got to move. And then I think finally, gosh, you know, we know all about the non-health aspects of HIV. We know about stigma and discrimination. We know how disparities, social disparities, economic disparities, gender disparities, safety disparities that show up in gender-based and other violence, how those totally impact and limit the effectiveness of a response as well. So as the COVID response continues to go forward, it's not an option not to address these social and economic disparities. And I think you touched on this with the last question about access to a vaccine, right? Yeah. Same thing when we talk about access to the right test at the right time, access to treatment, should it become available, access to a vaccine, should it become available. It can't be a matter of rich countries, rich people are first in line and everybody else is behind. It's got to be priority based on need. You know, healthcare workers everywhere, we've got to put at the front of the queue for these things. And then people who are most vulnerable, most at risk.
Absolutely,
Wonderful.
absolutely. Shannon, it's been fantastic to have you on. I'm so much of what you said then was it was just resonating, and I think again it's about, well, I guess one, we're talking about kind of the communities which suffer worst in any epidemic, in any pandemic, and it's those communities that are most marginalized. So we need to make sure that any solutions we find work for everybody. It's about that human rights approach. And as a queer man, you know, I've been horrified by some of the reports that we've received from, you know, from Hungary, from Uganda. So I'm just really glad that, you know, it seems that UNAIDS are really focusing really smartly, and I'm really grateful to have you as a colleague. So thank you so much for joining us today.
Thank you so much, Shannon. Take care. Wow,
that's it. That's our last guest.
And oh my goodness, that's our last guest and the end of the show. I think we've run out of time. So that's the end of the show for now, but I do hope that we will be coming back. But before we go, I would like to say a huge thank you to our wonderful guests. A massive thank you to the incredible team at Disruptive Live who have somehow put up with our tsunami of technical challenges. I like to say thank you to James from Stop AIDS for monitoring our social media, and our colleague Gus, who's also been doing that and some of the broadcasts, and also all of the NAM team who've been wonderful, beavering away behind the scenes without like the glory that Matthew loves, that I really hate.
Yeah, you said that with such conviction. I'm sure everyone believes you, Susan. And thanks to, I mean, all the amazing guests this week, to Winifred and Shannon and Julia, and to all the incredible guests that we've had on throughout the whole show. I was actually planning on listing them all, but we're running out of time, so we can't.
Really have run out of time.
We really have run out of time, and the people from Disruptive Media will want to go home for the bank holiday weekend. So it's been a joy to do this show. It's been a real eye-opener. It's been lovely to work with you, Susan. So we hope that we will come back in some format. Obviously, it's really interesting. What's been really encouraging about doing this has been the level of response we've received from all over the world, and people seem to like it. But please do let us know what you want us to do next, and if you want to see the show come back, let us know. That will always help make it more possible. So I guess that's it. Signing off.
I guess that's it. So thank you all so much, and hopefully we will see you soon. Thank you.
Thank you. Take care of yourselves. Bye.